Hello, this is Morton Kern. I'm going to talk to you today about aortic stenosis and the non-invasive and invasive assessment of this important valve lesion. These comments will be addressed in the setting of consideration for aortic valve replacement with percutaneous methodologies. The normal aortic valve has three cusps, each of which has a four-layered structure. The four layers include the endothelium, the fibrosa, the spongiosa, and the ventricularis as depicted on the graphic in the right. These fibers are aligned in both circular and radial fashion, and they result in the formation of very thin, strong cusps with a trileaflet coaptation as seen in the left-sided panel. Over time, in some individuals, calcific degeneration occurs and produces narrowing of the valves, rigidity, and stenosis. The most common etiologies of aortic stenosis are listed here, and the most common etiology we see in our country is degenerative aortic stenosis, where calcifications, degeneration of the leaflets, thickening, and rigidity occur. On the top left panel is the normal aortic valve, and on the lower right is a bicuspid calcific stenotic aortic valve with a atretic median raphe at the 6 o'clock position. Recall that the other etiologies of aortic stenosis include endocarditis, rheumatic fever, congenital deformation, and other varieties, as shown in the graphic of Goldberg on the right. The pathophysiology of aortic stenosis is demonstrated here in this cartoon. We see the narrowed aortic valve and the left ventricular outflow tract pressure. Moving toward the aorta, we see the aortic orifice area, and then just to the right of that, the effective orifice area. These changes in area are registered in the pressure gradients shown attached, with the maximal gradient occurring in the effective orifice area, and then moving into the aorta there is pressure recovery. So there is a slight increase in pressure as you move away from this most severe stenotic segment. Now these features of measured aortic pressure and LV pressure are responsible for differences that are identified between catheterization gradients shown on the upper right and Doppler echocardiographic velocity measurements and gradient calculations shown on the lower right. And the highest velocity is measured at the effective orifice area, producing a slightly higher pressure at times than the aortic catheter-based measurements, and that aortic catheterization hemodynamics do not always account for pressure recovery. So slight differences between these two characteristics should be recalled when assessing the aortic valve. In the non-invasive evaluation, cardiac murmur is a consistent and diagnostic finding for aortic stenosis, and in this graphic from the American College of Cardiology showing who needs an echocardiogram, all murmurs, with the exception of the mid-systolic grade 2 or less, or the asymptomatic mid-systolic murmur with no findings, do not need echo. Otherwise, systolic murmurs that are early, mid-systolic, late, or holosystolic, especially those associated with symptomatic disease, all diastolic murmurs and all continuous murmurs require echocardiography and subsequently cardiac cath in most circumstances. On physical examination, two maneuvers really differentiate the two types of obstruction to left ventricular outflow that might be confused with aortic stenosis. These two maneuvers include Valsalva maneuver and supine position leg raising. Why do these two maneuvers change the murmurs of hypertrophic obstructive cardiomyopathy and aortic stenosis in different directions? Well, the Valsalva maneuver decreases left ventricular filling and increases the obstructive component of hypertrophic myopathy. Thus, the murmur gets louder. In aortic stenosis with decreased volume return, the murmur becomes quieter as cardiac output is reduced. The opposite occurs in supine position with legs elevated, where the leg volume is transmitted into the central circulation, increasing the volume in the LV with obstructive myopathy and decreasing the murmur. And the opposite occurs with aortic stenosis with higher filling, higher output, and increasing the murmur. We use echocardiography as the hemodynamic non-invasive standard. On the upper left is an echocardiogram showing the four-chamber view, not the best seen to identify aortic stenosis, but is commonly used to assess associated findings of LV size, wall thickness, LV outflow tract dimensions, and other chamber function. On the lower left is the Doppler outflow tract velocity signal, and we know that 4v squared is commonly used as our gradient translation from the velocity measurement. The other important feature of echo is to provide prognostic information, and on the right in the classic graph from Catherine Otto, you see that the velocity across the aortic valve is associated with increasing mortality and decreasing event-free survival. So velocities less than 3 meters per second have a very high and good event-free survival. That's the blue graph. Those with 4 meters per second or greater in the velocity outflow have a very poor survival and higher long-term event rate. Let's take a moment and look at the hemodynamics. Here we see a normal left ventricular and aortic pressure tracing, in which the two measurements are made on a single catheter with a high fidelity micromanometer set of pressure transducers, one in the LV and one in the aorta. If we start our examination at the beginning of systole, that is at the end of diastole, if you drop a line from the QRS R wave to the LV pressure, you'll see that that is the LV EDP. Pressure rises with contraction isovolumetrically until the aortic pressure is reached, at which time ejection then opens the aortic valve, blood is ejected out of the LV. You see the anacrotic shoulder noted by the arrow and a small impulse gradient, which is normal in all people. The pressure continues until the T wave, at which time relaxation is signaled and pressure now starts to fall as the ventricle relaxes. You see the dicrotic notch and the fall of pressure back to the next systole. If we follow the LV pressure down to its minimum, that's the lowest pressure at the earliest point of diastole, and then across the diastolic filling period there is a gradual increase in pressure until the A wave, which follows the electrical P wave. The A wave is generated, and at the end of the A wave we start our cycle over again with isovolumetric contraction. Contrast this tracing to that in a patient with aortic stenosis. We now see the LV pressure in yellow and the aortic pressure in red, measured with a dual lumen pigtail fluid-filled catheter. There's a slight delay in the LV pressure, and we know this because the upstroke of aortic pressure looks to come a very short couple of milliseconds before it crosses the LV. So if we start with the LV EDP, isovolumetric contraction occurs. Note that the slope is slightly delayed. The crossing of aortic pressure at the D point shows the delayed upstroke in the aortic pressure as it enters the aorta. The peak is late. The peak systolic pressure in the LV is much greater, and the difference between these two tracings becomes the pressure gradient. In the cath lab, we use a simple quick measurement, the difference in peak-to-peak gradients as a determination of aortic valve severity. We can employ the hockey or quick formula to then compute square root of peak to peak under the cardiac output to determine valve area. We know that the mean gradient is what we should be using to calculate valve area. We also know that this delayed upstroke in the aortic pressure is responsible for our physical exam findings of a slow carotid upstroke, a single S2, and late peaking murmur. We should be employing the best technique to record aortic stenosis pressure measurements when we want this information, but many times we may be using a slightly older methodology whereby we use a femoral artery sheath and record the sidearm of pressure representing the aortic pressure, and then we use an LV pigtail catheter. And on the diagram to the right, we see the LV pressure, the aortic pressure, and the sheath femoral artery pressure. And it's important to recognize two things about the sheath pressure. One, it's delayed in time as it travels down to the leg. And two, it has a higher overshoot than central aortic pressure because of pressure amplification as the pressure waves reflect and resonate within the vascular tree. We should measure pressures unshifted if we employ this methodology for best results. Unshifted produces a slightly larger gradient, but it will not underestimate the valve area. Here is a list of techniques for measurement of aortic valve gradients from worst technique to best technique. The single catheter LV pullback is a rough measurement and unreliable for accurate data. LV and femoral sheath is commonly used but has the problems just identified. A longer aortic sheath in the central position reduces the femoral delay and overshoot. Bilateral femoral access, double lumen pigtail, transeptal access, pressure guide wire and ascending aorta with ascending aorta pressure, and multi-transducer micromanometers are all excellent methods, and the individual performing the procedure can elect. In our laboratory now, we use a radial access with a double lumen pigtail and a brachial vein through percutaneous techniques. These are very effective, and we do not have the problem with femoral bleeding as we did in the past. Calculating aortic valve area is performed with two equations. The top one is the complete Gorlin formula, and the lower one is the hockey or quick formula. This is also known as a poor man's Gorlin, and you can easily see that cardiac output divided by the square root of the peak-to-peak pressures will give you a close approximation to Gorlin's formula when the heart rate remains within 65 to 100 beats per minute. The grading severity of aortic stenosis is listed here. Aortic valve areas and aortic valve index are shown. Mild aortic stenosis has a valve area of greater than 1.5 centimeters squared. Moderate aortic stenosis is 1.1 to 1.5, and severe aortic stenosis is generally considered less than 0.8 or less than 1.0 centimeters squared. These are common numbers applied both from echo and hemodynamic data. The hemodynamic differentiation of outflow tract obstruction can be determined by examining the response after a premature ventricular contraction. On the left, we see a premature ventricular contraction followed by a pause and then a large pressure gradient. Note that the upstroke of aortic pressure is still delayed, that the pulse pressure is wide, and that the configuration of the aortic pressure the same as its family of other beats. On the right is left ventricular premature beat in a patient who has obstructive cardiomyopathy. Note that at rest the hemodynamic gradient across the LV outflow tract is nearly zero, but after the PVC beat the large gradient is identified. The difference, however, between hypertrophic obstructive myopathy and AS is that the pulse pressure of the aorta is lower, the configuration of the beat markedly different with a spike and dome pressure in the aorta, and the aortic pressure upstroke is nearly vertical. The size of the gradient is irrelevant, but the characterization of outflow tract obstruction being of a dynamic type is shown by this beat. Otherwise, the outflow tract would have a fixed component and the slope of aortic pressure would be delayed. The three features again are aortic pressure upstroke being delayed, pulse pressure contour being smaller, and the spike and dome pattern seen in hypertrophic obstructive myopathy. A common problem that we face when assessing aortic valves are those patients who have low gradients and low ejection fractions with aortic stenosis. Here is an example which will demonstrate this concept. In this patient, he has an ejection fraction of 25%, a peak-to-peak gradient of 30 millimeters mercury, a cardiac output of 3.2 liters per minute, and an aortic valve area calculated at 0.7 centimeters squared. His pressure tracing is shown on the right. The question is, would this man benefit by having aortic valve replaced, since his calculated aortic valve area is 0.7? Is this fixed or dynamic obstruction? Dynamic meaning with increasing cardiac output, would the aortic valve open more? To answer this question, we perform a dobutamine challenge for low gradient AS. Here are three pressure tracings obtained during dobutamine infusion with pacing at 80 beats per minute with an infusion of 10 micrograms per minute and then an infusion of 20 micrograms of dobutamine plus pacing at 95. From baseline to maximal dobutamine, you see the gradient now increased to 50 millimeters mercury with a small increase in cardiac output, but the aortic valve area calculates at 0.6 centimeters square. What does this mean to us? If we look on the curves, which are plotted from transvalvular gradient on the vertical and transvalvular flow on the horizontal, we see that we are at a position at the beginning of this arrow which talks to us about the size of the gradient, the increase in gradient, and the increase in flow. And we stay on the curve that tells us our aortic valve area is fixed at 0.7. If we had a different response, that is, if the gradient had not changed much, despite having the cardiac output increase a lot, this would mean the valve area could open more, and we would have moved to a higher valve area curve, off the curve that indicates fixed aortic stenosis. So we use dobutamine to differentiate these two conditions. There is a new concept of low flow, low gradient aortic stenosis with normal or even depressed ejection fraction. We understand about depressed ejection fraction, whereby we can increase its action and test the response with dobutamine. We have lesser understanding of those patients with normal ejection fraction, low flow, low gradient aortic stenosis, in whom we believe this is a strong diastolic dysfunction and peripheral vascular resistance problem. At this current time, these patients are under study, but indeed have similar poor outcomes as those with aortic stenosis untreated. This is the data from Clavel showing that in the paradoxic low gradient severe aortic stenosis group, PLGSAS, you see that with medical therapy they have the same outcome as the high gradient severe aortic stenosis group untreated. The response to valve replacement seems to improve their outcomes as it does with the other group. Let's look for a moment at the current activity with percutaneous transaortic valve implant or transaortic valve replacement as it is now called. On the left is the core valve, and on the right is an early version of the Edward Sapien prosthetic heart valve. These are remarkable devices which I'm sure in the future will revolutionize the way we treat patients with aortic stenosis. Here's an example of hemodynamics before and after aortic balloon valvuloplasty, often required before percutaneous heart valve implant. Note on the left the slow upstroke, the large gradient, and the position of aortic pressure. On the right, after balloon valvuloplasty, we see several changes. First, the upslope of aortic ejection is steeper, the peak aortic pressure has increased, and the peak LV pressure has decreased. These are findings you want to observe for a successful balloon valvuloplasty, and likewise you want to see these same findings. Here is a patient who has an unusual association with aortic stenosis. Note the marked decline in aortic pressure matching the rapid rise in LV end diastolic pressure on the middle beats. The aortic pressure falls and is now nearly on top of LV pressure. This is a patient who has both aortic stenosis and marked aortic insufficiency. Aortic insufficiency is characterized by a narrow end diastolic pulse difference, a large pulse pressure, and a rapid increase in diastolic filling across the diastolic filling period of LV tracing. When we now conclude and summarize who needs aortic valve replacement or who needs a percutaneous aortic valve, we can look here in the diagram from the American Heart Association and American College of Cardiology consensus papers and see that severe aortic stenosis in patients who have symptoms are often directly referred for valve replacement with class 1 indications. If the symptoms are equivocal or there are no symptoms, then we need to perform exercise testing, and if exercise testing reveals symptoms or decrease in blood pressure, they become a class 2B candidate for aortic valve replacement. If their exercise test is normal but their ejection fraction is less than 50%, they now are a class 1 indication for aortic valve replacement. If the ejection fraction is normal but there's severe calcification, rapid progression, or expected delays in surgery, we have to decide about a class 2B indication or whether they should continue on medical therapy and be reevaluated. I want to thank you for your attention to this presentation and look forward to doing more for you in the future.